This week's work will be focused on abdominal pain. The learning outcomes for this week include defining the term abdominal pain, list the various diagnostic triads, describe the key features of each of the diseases covered in these diagnostic triads, review the labs mentioned, and review the significance of the physical signs encountered in this presentation. Our index patient is the middle child, 11-year-old Zoe Sikalot, the daughter of Brian and Maria. Zoe has been having recurrent abdominal pains for the last 3 weeks. Let's talk about the incidence of abdominal pain. The word incidence, remember, means the number of new cases of a particular disease in a particular location in a particular year. Following the Murphy's three-question approach, where the first question was, are there any red flags to rule out? Second question is, what's the generator of the symptom? This is abdominal pain, and this is one of the situations where we're going to use our knowledge of anatomy to help us to generate a variety of differential diagnoses depending on where exactly the abdominal pain is located. So if the patient presents with epigastric pain, think of what are the organs that are in this region. It's the stomach, it's the gallbladder, it's the liver, it's the pancreas, and therefore we should think of, is it pancreatitis, is it cholecystitis, is it hepatitis, or is this peptic ulcer disease? We do the same for the right upper quadrant. What are the organs are in that region? Is basically the liver and the gallbladder. Again, could this be hepatitis or cholecystitis? If it were in the right iliac fossa, what are the organs that are there? It's the appendix, it's the terminal ileum, it's the right fallopian tube, it's the right ovary. So could it be appendicitis or Crohn's disease or salpingitis or a twisted ovarian cyst? So I'm not going to go through all 9 regions of the abdomen, but it would be good to reflect on imagining in yourself, if you put your hand over your epigastric region or your periumbilical region or your left lower quadrant, left iliac fossa, which organs are likely to be underneath there and what diseases are likely to be associated with these sites. Having said that, you should be aware that sometimes pain arising from a particular organ may not arise in the area where that organ lies, and it may arise elsewhere. So, for example, and this has to do with the embryological origin of the intra-abdominal contents. If the organ is derived from the foregut, which will include the lower end of the esophagus, the stomach, the duodenum, and the pancreas, and the liver and the gallbladder, patients might complain of pain to start off with in the epigastric region, and as the disease becomes more evident in the gallbladder, that pain may radiate to the right upper quadrant or right hypochondrium. Similarly, organs or parts of organs that are derived from the midgut, which would include the rest of the duodenum, all of the small bowel, the cecum, the ascending colon, and the proximal two-thirds of the transverse colon. When you have pathology arising from one of these derivatives, they will present first of all with periumbilical pain and then classically radiate to where the organ is actually located. So in the case of acute appendicitis, the appendix, as you just remembered in the previous diagram, lies in the right iliac fossa. You do not get pain in the right iliac fossa to start off with. The pain is referred to the umbilical region, and then after approximately 6 hours, that pain radiates to the right iliac fossa. Same for terminal ileum pathology, periumbilical pain, then it radiates later. You have a similar phenomena happening with derivatives from the hindgut. The rest of the transverse colon, all of the descending sigmoid and rectum are going to give you pain referred to the suprapubic or hypogastric region before it may then go to the left side or towards the back in the sacral region if this is the rectum. So bear that in mind. Also bear in mind that patients with gallbladder problems may present with pain towards the back between the two shoulder blades. Patients with splenic infarcts may complain of pain in the shoulder rather than pain in the left hypochondrium. Any questions? If not, let's look at the first of 9 diagnostic tries. This is pain in the upper abdomen, whether it be epigastric, right hypochondrium, left hypochondrium. We're just going to look at 3 big ones in the epigastric region or the upper abdomen. The first is pancreatitis. And remember, we are going to be talking about those conditions that are more of a red flag situation that needs urgent diagnosis and then urgent referral. So pancreatitis is one of the 3. Not all 3 are going to require immediate or urgent referral to the hospital. Pancreatitis, as the name suggests, is inflammation of the pancreas. This could be acute or chronic. We're talking about acute pancreatitis. Common causes would be infection of the pancreas, could be inflammation of the pancreas caused by alcohol, or it could be induced by gallstones. Gallstones being stuck somewhere in the common bile duct may cause reflux of bile into the main pancreatic duct of Versung. This may spill out into the surrounding pancreatic tissue, causing inflammation. Patients with acute pancreatitis are going to present with severe epigastric pain to start off with, because remember, the pancreas is a derivative of the foregut embryologically. It may follow an alcoholic binge, or it may be associated with gallstones. Very rarely would you have these 2 signs, Cullen's and Gray-Turner signs. Both of these are going to present as bluish discoloration. Cullen sign is going to cause discoloration around the umbilicus. gray Turner sign is going to cause discoloration in the flanks, and both of them are associated with a severe form of acute pancreatitis called hemorrhagic pancreatitis, where the digestive enzymes spill out from the inflamed, swollen pancreas and start to dissolve the blood vessels that are found in the retroperitoneal region, because the pancreas, 90% of the pancreas is retroperitoneal except for the tail, which is intraperitoneal. So it will cause disruption, destruction of the blood vessels. You get retroperitoneal bleeding. This seeps around in the peritoneal wall to give you gray Turner's and Cullen's sign. Should you make the diagnosis of acute pancreatitis, refer the patient urgently to the hospital. When they get to the hospital, the doctors are going to order specific tests, including serum amylase and serum lipase. They're going to order a CT scan to show the edematous, swollen, inflamed pancreas, and they may even be able to pick up the stone in the common bile duct that may have triggered the acute pancreatitis. If the patient comes in smelling of alcohol or has a history of an alcoholic binge over the weekend, they're going to be ordering your comprehensive metabolic panel, looking for increase in your AST, ALT, and GGT. Cholecystitis is the other red flag situation where if you make the diagnosis, you're referring the patient urgently to the hospital. Cholecystitis is inflammation of the gallbladder. Itis means inflammation. Chole to do with bile, and cysto to do with the bladder. So it is inflammation of the bladder that contains bile. Escherichia coli is the most commonly associated bacillus that is coming up from the bowel into the common bile duct situation, and it's seen more commonly in overweight females. The classic presentation of a patient with acute cholecystitis is a fair, fat, fertile 40-year-old female who presents with sudden onset of right upper quadrant pain associated with recent eating of fatty meals. There may be a low-grade fever, and Murphy's test, which we will talk about more in detail when I see you back in the final hour at the end of the week, is likely to be positive. Labs would include complete blood count, which shows leukocytosis and neutrophilia. Ultrasound of the gallbladder is the preferred initial imaging, but the CT scan of the abdomen is the gold standard. X-rays are not recommended if you suspect cholecystitis, because X-rays will only pick up 15% of gallstones, and that's only the gallstones that are made up of or has calcium inside. The majority of gallstones don't have calcium inside. They're made up of cholesterol and therefore will not be seen on most X-rays of patients with cholecystitis. But if it's there, then yes. Management, as I said, is referred to the hospital. They will do all of the blood tests, the ultrasound of the abdomen, and the CT scan to prove that this is cholecystitis. Here is what the ultrasound is going to look like. Anytime you see the top of the image is curved like that, and you can see layers of skin through which the sound is going to pass through, and it's kind of wedge shaped in picture, you're dealing with an ultrasound. And here is the inflamed gallbladder with at least 4 stones seen. And you're probably going to ask, why could this not be just gallstones, cholelithiasis? the gallbladder is inflamed. Here is what the normal thickness of the gallbladder is, and over here the thickness has doubled, and you have signs of inflammation and edema of the wall of the gallbladder there. So the presence of stones and right upper quadrant pain does not necessarily make this cholecystitis. If the patient had a fever and the gallstones, then yes, this is diagnostic of cholecystitis. This is what the CT scan of the abdomen. This is the left side. This is the right side. This is the large liver. This is the gallbladder. It is distended, and there are 3 stones in the gallbladder there. This is the pancreas there. This is the stomach over here. So this is what the CT scan of the abdomen in a patient with right upper quadrant pain and fever that was triggered by eating fatty meals. That is your gallstones that are characteristic of cholecystitis. 85% of all patients with gallstones are asymptomatic. Only 15% of patients with gallstones will have evidence of inflammation of the gallbladder. On the other hand, 95% of patients with cholecystitis, evidence of inflammation, pain, swelling, fever, are going to be associated with gallstones. So it begs the question, okay, if gallstones are not present in a patient with classic signs and symptoms of cholecystitis, right upper quadrant pain, they're fair, they're fat, they're fertile, they have 4 children, they're in their 40s, and having a hamburger with all of the trimmings triggered the right upper quadrant pain and fever, but there are no gallstones present. What is the cause of that? Sometimes the stones don't present. They are in a dissolved sediment called biliary sludge, and that biliary sludge could be infected with E. coli, and that will then trigger the gallbladder inflammation. And then the other of the 3 conditions that is going to cause upper abdominal pain is peptic ulcer disease. This is not a red flag situation. This is, you recognize this, you refer the patient off to a gastroenterologist and you co-manage the patient. Peptic ulcer disease is defined as formation of ulcer either in the stomach or the duodenum. 75% of all peptic ulcers in the stomach are caused by an infection by Helicobacter pylori. The other 25% could be a combination of injudicious use of non-steroidal anti-inflammatory drugs. You tell them to take this with a meal, they forget because the pain was too intense, they took it on an empty stomach, and a week later, 2 weeks later, they have developed symptoms and signs of peptic ulcers in their stomach. Occasionally, it might be associated with burns or with severe physical stress. 95% of all peptic ulcers in the duodenum are related to H. pylori infection. Patients with peptic ulcer disease, whether this is going to be a gastric peptic ulcer or a duodenal peptic ulcer, would present with epigastric pain. And if the epigastric pain is worse with eating meals, that places the ulcer in the stomach. The pathophysiological explanation is straightforward. If you have a sore, an open sore in the lining of your stomach, you're going to put food in it. The food triggers the release of gastrin. Gastrin triggers the release of hydrochloric acid from the parietal cells. Hydrochloric acid is going to burn that sore and make it more painful. If there is epigastric pain that is better with eating meals, then it's not located in the stomach, it's located in the duodenum. Labs that are useful, You can take blood off and look for H. pylori antibodies. The H. pylori antibodies will tell you you have been exposed to H. pylori in the past. It doesn't tell you your current epigastric pain is due to current Helicobacter pylori infection. A much better test is the urease breath test, and we talked about that in end of week 4, early up in the course, where you give the patient specially manufactured urea in the lab. And if the patient has H. pylori, Helicobacter pylori is a gram-negative multipolar bacillus that is urease positive, then the urease that is produced by the H. pylori is going to break down the urea that you've asked the patient to swallow, and then the byproducts of that would be ammonia and carbon dioxide. Carbon dioxide is then goes to the blood, excreted via the lungs, and because you're using carbon dioxide with a small radioactive label, carbon 14, you can pick this up with a specialized radioactive counter instrument in the lab. Management of a patient with peptic ulcer disease is co-managed with a gastroenterologist. The gastroenterologist is going to scope the patient, see the ulcer, biopsy the ulcer, send it off to the lab, and it will come back H. pylori is present or H. pylori is not present. You could, if the patient is amenable to your recommendation, offer in the meantime them going to the health food shop, getting a week or two supply of probiotics, which will then counter the overpopulation and growth of H. pylori, which will then cause the H. pylori infection to then subside, waiting for the diagnosis to be confirmed by the gastroenterologist. Any questions on this first triad? Let's look at another 3 important conditions that will cause lower abdominal pain. And again, we're going to start off with those conditions that are possible red flag situations that need to be diagnosed promptly, and then an urgent referral to the hospital. The first is appendicitis. Appendicitis is inflammation of the appendix. The majority of your appendicitis is acute. Very rarely do you have chronic appendicitis, which may take days or weeks to then fully manifest. Most of it is going to be diagnosed within the first 24 to 48 hours. It could be either bacterial or viral. And the clinical picture is periumbilical pain. Remember, the appendix comes from the midgut. And initially, any midgut derivative that is inflamed will give you periumbilical pain until hours later, you're going to have fever and the pain radiating to the right iliac fossa. When it is there, you can have possibly one of 4 signs that are positive: Rossing's, psoas, obturator, McBurney's signs or tests might be positive, and we will, when I see you at the end of the week, we will go over each of these 4 tests. We'll talk about what they mean and how to interpret this. Should you suspect appendicitis in a child, that's the most common presentation, but it could uncommonly present in adults and even less common in the elderly. They would have the same presentation: periumbilical pain radiating to the right iliac fossa associated with fever. You should refer the patient to the hospital. As I said in the introduction, this is the most common disease that needs surgery as an intervention to cure the disease, but there's a growing sentiment among surgeons that appendicitis, especially acute appendicitis, could be easily treated with a course of antibiotics, which would be much more cost effective than 3 days stay in the hospital, surgical equipment use, the theater equipment being used. You need an anesthetist in addition to the surgeon, etc. And this started off from um, the COVID days where doctors were busy with more urgent situations. Patients were dying on an hourly basis from COVID-19 lung infection or septicemia. And they were then kind of said, okay, can we put this patient on 24-hour antibiotic and see what happens? Just have the nurse monitor them on an hourly basis, looking for changes in their blood pressure, temperature, pulse, and respiration. Every hour they go back and they do the equivalent of the Blumberg test and see what happens. And if the patient's fever spikes, the pain gets worse, and the Blumberg sign is positive, then that patient is no longer treated with antibiotics. They transition to surgery and they take out the appendix, which is curative. Labs that will go along with acute appendicitis would be complete blood count showing leukocytosis. If this were a viral infection, there would be an increase in the lymphocytic population. If there was a bacterial infection, there would be neutrophilia. CT, spiral CT scan of the abdomen is the gold standard for confirming the presence of an inflamed appendix. And this is what the arrow points to, the swollen appendix on the right side of the iliac fossa here. And that's it. There's been a debate in the past whether you could use the less expensive, less radiation ultrasound. Ultrasound for appendicitis is not as sensitive and specific as your spiral CT scan. The other cause of lower abdominal pain that will require hospitalization is diverticulitis. Diverticulitis is inflammation of large bowel diverticula. If there are diverticula present without inflammation, then the diagnosis is called diverticular disease or diverticulosis. Osis, a condition in which you have diverticula but it's not inflamed, so you're not calling this itis. Causes of inflammation of these abdominal large bowel diverticula would be E. coli, and there's a possible link between lack of dietary fiber, which will predispose the patient to having raised intracolonic pressure, and that raised intracolonic pressure will then cause these herniations that present as diverticula. Classic picture, lower quadrant pain on the left side, and some patients with diverticulitis may present with bright red blood in the stool, and this is called hematochezia. The combination of bright red blood in the stool, left lower quadrant pain, fever in an older person, usually men, is diverticulitis. Refer the patient to the hospital. In the hospital, the doctors are going to, one, confirm the presence of the diverticula by doing a spiral CT scan and evidence of the itis, the inflammation, by ordering a complete blood count and noticing a raise in the white blood cell count. The other cause of pain in the lower abdomen that is not for urgent referral to the hospital is bacterial cystitis. This is inflammation of the bladder. It is more common in females than males because of the short urethra in females, 1 3/4 inches, compared to 8 inches in the male. Causes, the most common bacteria associated with bacterial cystitis is E. coli, but then it could be caused by Enterobacter fecalis, uh, Klebsiella pneumonia, Proteus mirabilis, Pseudomonas aeruginosa, Sriracha marcescens, or Staphylococcus saprophyticus. The mnemonic you should keep in your head is KEEPS. KEEPPSS. K for Klebsiella, E for E. coli, second E, Enterobacter fecalis or cloacae, first P, Proteus mirabilis, second P, Pseudomonas aeruginosa, first S, which is associated with red pigment, Sriracha marcescens, and the last S, which I want you to keep in mind, is Staph saprophyticus. All of the other 7 organisms are gram-negative bacilli, except the last, which is a gram-positive coccus. And that gram-positive coccus stands out as an exception to the rule that affects the other 7 gram-negative organisms. The clinical picture is suprapubic pain, dysuria, which is burning or difficulty passing urine, increase urinary frequency during the day, getting up more than 2 times at night to pass urine. That is called nocturia. And when the urine is examined visually, it is not clear, it is cloudy. Labs would involve ordering a routine analysis of the urine. So this is a routine urine analysis. You're looking primarily for nitrites. The presence of nitrites indicates the bacteria that are causing the infection contain an enzyme known as nitrate reductase. Now, all of the 7 causes of urinary tract infection that we talked about, KEEPP, and the first S, are nitrite positive. The only one that is not nitrite positive because it does not contain nitrate reductase is the last S, which is Staphylococcus saprophyticus, the only gram-positive organism of all of the 8 organisms. You are also going to see leukocyte esterase. This is an enzyme, an esterase enzyme. It breaks down esterase, and it's produced by white blood cells that are caused by the concomitant bladder inflammation. You're also going to see numerous bacteria, and the lab will report more than 100,000 colonies per high-powered field, and that is diagnostic of a urinary tract infection from a laboratory perspective. Management of a patient with bacterial cystitis co-managed with a medical doctor if cranberry juice does not help. Now, some people may prefer not to use cranberry juice, but use the cranberry juice concentrate in capsules. It contains a concentrated form of the particular compounds that are useful in preventing E. coli and other bacteria from sticking onto the inside of the bladder wall and then colonizing the bladder wall and then causing an infection. If that does not work, I prefer to use cranberry juice because not only are you getting the active ingredient, even though it's in a dilute form, you're getting 1 to 2 liters because I'm going to ask you to buy a 2-liter bottle and finish that 2-liter bottle in 1 day. And if by the end of the 2nd or 3rd day you are not better, don't come back and see me. Go and see your medical doctor, who will then hear your story, dysuria, frequency, nocturia, make the diagnosis of bacterial infection. Don't even bother send your urine to the lab, which I think is not the best practice, but put you on a course of antibiotics for 5 to 7 days with the instruction that if you are not better in 3 days, come back and see me. And if you are not fully asymptomatic at the end of the course of the antibiotic, come back next week and let's see what else is going on. Any questions? The next triad is the triad in which abdominal pain is associated with diarrhea. The first of the three conditions that is going to present with abdominal pain and diarrhea is irritable bowel syndrome, abbreviated IBS. Do not confuse IBS with IBD. IBS, as I said before, stands for irritable bowel syndrome. IBD stands for inflammatory bowel disease, and there are two causes of IBD: Crohn's disease and ulcerative colitis, which also present with diarrhea and are included in this diagnostic triad of abdominal pain with diarrhea. IBS, irritable bowel syndrome, is a collection of symptoms which include abdominal pain that is related to bowel movement. There's a particular criteria we'll talk about shortly. The cause today, we think it's a problem with the gut-brain axis. In my days, we thought it was a problem with the brain-gut axis. We thought that since many people with irritable bowel syndrome also suffer from anxiety, it's their bowel reacting to the anxiety created by the brain. That was the thought 30, 40 years ago. We now know that we've had this all the wrong way. We now know it is caused by a problem with the bowel, which then messes with the neurotransmitters, dopamine and serotonin, which is going to have a deleterious effect on our mood, which actually is the situation. So now our attention is not trying to find psychiatric drugs to treat this condition, but finding ways to manipulate the diet in order to restore the proper connection between the gut and the brain. Clinical picture: abdominal pain relieved by defecation. That is one of specific criteria according to the Rome 3 criteria that the American Association of Gastroenterologists has been using for the longest while to make the diagnosis of irritable bowel syndrome. So in addition to having abdominal pain relieved by constipation, you could have either constipation or diarrhea or both. So in the Green Book, Chiro Essentials Differential Diagnosis, you will see the Rome 3 criteria, and it says you need to have either a change in the frequency of passing stool, either increase or delayed, so diarrhea or constipation, or a change in the consistency of the stool, either less liquid, that would be associated with constipation, or more liquid or fluid, that would be with diarrhea. So there are three varieties of irritable bowel syndrome depending on what's associated with either constipation or diarrhea or both. So it's IBS-C if the predominant abdominal feature besides the pain relieved by defecation is constipation. IBS-D if diarrhea is the problem. And then IBS-B if the symptoms associated are both diarrhea and constipation. Not both are the same. You can't have both. So it will be diarrhea followed by constipation, followed by normal, followed by more constipation, followed by diarrhea. So you have both manifestations. No labs are necessary because the diagnosis is made primarily on the history. Management: co-manage with a cognitive behavioral therapist. Acupuncture is superior to medical drugs. Chiropractic care is helpful, but there's not been a back-to-back study comparing chiropractic care, meaning spinal manipulative therapy, SMT, opposed to the arm that is drug treatment. We have isolated case studies that show a patient with IBS. If you, and this is what I don't like with some of the case studies, they don't do a, let's just do chiropractic care. If there is a recurrent subluxation, lower thoracic, upper lumbar region, and we adjust the patient, let's compare that with if they go to the medical doctor and they get treatment with whatever drugs the doctor is going to use. Or you could have a third arm where we do nothing and see what happens. What happens with a lot of these case studies, you will see the author of the study says, in addition to having chiropractic care, we put them on probiotics and we adjusted the diet. We had them eat more anti-inflammatory um, foods like kimchi and kombucha and all of that wonderful grass that they chew up in a cocktail. Um, and I read these and I go, so which worked? The probiotics, the kombucha, the kimchi, or was it the chiropractic adjustment? The other cause of abdominal pain with diarrhea would be Crohn's disease, one of the two causes of inflammatory bowel disease. Crohn's disease is defined as a chronic gut inflammation. We do not know what is the underlying etiology. We have not been able to prove there is a specific infective organism. We've looked for this for 2 centuries. We don't know whether this is an autoimmune because we're not finding any specific antibody produced in excess. Uh, we don't know. Classic picture, right lower quadrant pain. They start off with periumbilical pain radiating to the right lower quadrant. There is no fever. There is diarrhea. And the reason the pain is usually located in the right lower quadrant is that even though Crohn's disease could affect anywhere along the entire GI tract from the esophagus all the way down to the rectum, the majority of patients with Crohn's disease have the disease located in the terminal ileum. So an old fashioned term for Crohn's disease is terminal ileitis because of the focus on the terminal ileum. Therefore, if the terminal ileum is inflamed on a chronic basis, you're going to find pain in the right lower quadrant. There's going to be diarrhea. There's going to be fatigue. The fatigue is due to the fact that if you have a chronically inflamed terminal ileum, and you remember that the terminal ileum is the place where all of your B12 is going to be absorbed, you're likely to suffer from malabsorption of B12 and then run into a problem with fatigue, beefy red tongue, and a macrocytic normochromic anemia. Patients with Crohn's disease, occasionally it may affect their eyes, causing an iritis, or may affect their joint. And when it affects the joint, it's usually those patients with Crohn's disease that have a particular HLA configuration of their white blood cell antigen, and that is the HLA B27. Remember, HLA B27 causes 4 types, or is associated with 4 diseases that causes arthritis: psoriatic arthritis, enteropathic arthritis, ankylosing spondylitis, and reactive arthritis. And it's the enteropathic. Enteropathic means the pathology is in the bowel, and you can get this in both Crohn's disease and ulcerative colitis presenting with bilateral sacral ileitis, and then other features that may look like ankylosing spondylitis, except it is associated with diarrhea. You should co-manage this patient with a gastroenterologist. There again been case studies showing patients with Crohn's disease, if you adjust them, whether it's a cervical adjustment or a mid-thoracic or upper lumbar adjustment, it helps. And there is some um, scientific evidence to suggest a possible mechanism. The latest studies in the pathophysiology of patients with Crohn's disease, they have isolated it to a problem with overstimulation of a particular branch of the vagus nerve that goes to the spleen and then is distributed to other parts of the bowel. And in these experiments, written up in recent journals of gastroenterology, if they can stimulate the vagus nerve either by having an internal device planted in the neck or an external device stimulating it from the outside, you can modulate the parasympathetic tone in the autonomic nervous system, and this will abate the frequency and duration of the signs and symptoms of Crohn's disease. You know that with an upper cervical adjustment that you actually could be affecting the sympathetic or parasympathetic depending on which one needs to be modified by the innate. So there is some evidence as to how chiropractic care might be useful, and therefore this is why I've put here co-manage with a gastroenterologist. Because of the possible loss of vitamins in the bowel, CBC should be ordered to see if there's anemia. The diagnosis is confirmed by getting access to the small bowel, wherever the small bowel is inflamed. If you can get a piece of that tissue, send it off to the histopathologist, it will show non-caseous granulomatous inflammation of the tissue being biopsied. From a radiological perspective, you could learn with Dr. Che later on that there's a particular study using barium sulfate where you ask the patient to drink a certain amount of this radiopaque material. You wait for a couple of hours when it passes through the esophagus and stomach and duodenum and gets into the small bowel, and then you take a picture hours later. I don't know how many hours later. What you will see is a characteristic radiological sign called the string sign of Cantor. This is what the string sign of Cantor looks like. This is a patient who has been given barium to swallow. The barium has gotten into the small bowel. This is loops of small bowel there, and then it comes down just before it gets into the cecum to then enter the ascending colon, transverse colon, and descending colon. Here is this thin strip of barium passing through because the wall of this is inflamed, and therefore the lumen is narrowed, and therefore instead of filling up the small bowel, as it shows here, remnants of the barium sulfate, it passes through and shows you a very thin line there, and that is called the string sign of Cantor. You could be tested on this. I could show you an x-ray in the next examination. I could ask you a simple question. The string sign of Cantor following the ingestion of barium sulfate is associated with which disease? Or I could give you a clinical vignette of a 34-year-old female with right iliac fossa pain and recurrent diarrhea, no hematochezia, and then ask you which of the following 5 statements are correct. Select 2. And one of the choices may be The most likely diagnosis is Crohn's disease. A second choice could be the string sign of Cantor is likely to be present. I might replace the string sign of Cantor with lead pipe, appearance of a barium enema, which we will learn later as classic for ulcerative colitis, and then replace that with another correct statement like this patient is most likely to suffer from a macrocytic normochromic anemia, in parenthesis in your head, because I'm not putting up parentheses there in the examination, B12 deficiency. Okay, and here is the next of the two causes of IBD, inflammatory bowel disease. This is ulcerative colitis. This is an autoimmune gut disorder of unknown origin. And unlike most other autoimmune conditions in which there's a increased preponderance of middle-aged females with this disease, the sex, there's no difference between males and females with ulcerative colitis. They're equally affected. Clinical picture of this condition that affects the colon, hence colitis, is left lower quadrant pain with diarrhea and hematochezia, which is the presence of bright red blood in the stool. Like with Crohn's disease, co-managed with a gastroenterologist. Unlike Crohn's disease, there's not been an awful lot of articles written in the chiropractic literature saying that ulcerative colitis can be managed quite comfortably with chiropractic adjustments. The diagnosis is going to be confirmed by your referring this patient to a gastroenterologist who would make the diagnosis tentatively from the history, and he will then do a colonoscopy or a sigmoidoscopy. There's a difference between the two. A colonoscopy is using a flexible tube with a telescope on the end, camera on the end, and it would look through the rectum, the sigmoid colon, the descending colon, transverse colon, and then ascending colon right up to the cecum and ileocecal valve, which is a long tube, or just using an 18-inch rigid tube called a sigmoidoscopy, because 90% of all of the patients with ulcerative colitis, the problem is located in the sigmoid or sigmorectal junction. A complete blood count is going to reveal this particular type of anemia, a microcytic hypochromic anemia. And why is that? Because the ulcerations that are seen on the colonoscopy bleed easily. And if you're going to bleed easily in your bowel and you're going to get bright red blood in the stool, you're going to lose iron, and therefore you're going to get the morphological type of anemia associated with an iron deficiency. Barium enema will then reveal the classic lead pipe appearance. This is what the barium enema in a patient with ulcerative colitis looks like. A certain amount of barium sulfate was introduced via the rectum. It fills up the sigmoid colon, fills up the descending colon, transverse colon, ascending colon, and over here in the ascending colon, you can still see remnants of the indentations caused by the haustra. Some still here, but for the rest of the descending colon and transverse colon and the sigmoid colon, there are no haustra whatsoever that are found. This is what is called the lead pipe appearance. Any questions? All right, so let's look at the combination of abdominal pain and vomiting. Again, we're going to start off with the more urgent diagnoses that are going to require an urgent referral to the hospital and end up with, okay, you're going to either refer to a specialist or co-manage with somebody else. This is generalized peritonitis. This is inflammation of the abdominal peritoneum throughout the entire abdominal cavity. There are two main causes. Bowel perforation, so some pathology from the inside has caused the bowel to rupture from the inside, or you have penetrating gut injuries, knife wounds, bullet wounds, steel bars at an industrial site, penetrating the abdominal wall, perforating the bowel from the outside. Regardless of whether this is intrinsic, internal bowel being disrupted, or extrinsic, some force from the outside going on to the inside, the clinical presentation will be the same. Severe abdominal pain, vomiting, absent bowel sounds. Make a big note about in generalized peritonitis, bowel sounds are absent, and then Blumberg sign, which we will talk about later, should be considered but not done. And I'll explain the discrepancy. So Blumberg sign, which is a sign of rebound tenderness, will be present, but it's not recommended in the American Medical Society for a doctor to do a Blumberg test on the patient. Think of generalized peritonitis in the following context. When I was taught about this in med school, my surgical professor said to me, or said to us in the class, think of generalized peritonitis as a silent dog. You go up to the gate, there's a dog on the inside of the gate, and he is looking at you with those non-committal eyes. There's no growling, no wagging of the tail. You don't know what is going on. And if you were to go inside and step into a step, he would then probably attack you. So view generalized peritonitis like a silent dog. It's likely to attack you out of the blue. Now, any movement inside the abdomen will cause problems. So if you were to take your hand from the outside and push down into the abdomen in any area, that's going to cause pain. If you're going to poke your hand ever so slowly and take your hand off suddenly, that jerky movement will cause pain. Movement of the bowel inside will cause pain. Hence, everything is silent. Like a silent dog that does not bark, view the absent bowel sounds as ominous. If you make the diagnosis of generalized peritonitis, refer the patient urgently to the hospital. If the fever is high and you know what the temperatures above which you are going to call 911, if the patient is going into septic shock, blood pressure drops below 90/50, the pulse rate is above 120, the respiratory rate is 30 and above, you may want to consider bringing the hospital to the patient via a 911 call rather than risk putting them in the back seat and having a relative drive down a busy road, swerving here and there, going into potholes, which might cause further disruption. So either urgently refer to the hospital, or if the vital signs are affected, call 911. They will take a film, a straight abdominal, an erect abdominal picture, and they're looking to see if there is air free in the abdominal cavity. This is called pneumoperitoneum. So here is a straight erect film of a patient with a perforation of the bowel. And instead of looking and finding a air bubble underneath the left dome of the diaphragm, that air bubble way over that side is not in the stomach. That's in the splenic flexure of the descending colon. We're looking for air that is likely to be in the area of the left midclavicular line. It's not straddling the left midclavicular line. The air is absent, and look where the air is gone. The air is gone underneath the right dome of the diaphragm, between the dome of the diaphragm and the liver. So that is air in the free air in the peritoneum, not confined to the bowel, and that is called pneumoperitoneum. The presence of pneumoperitoneum will confirm that the bowel has been perforated. In this particular case, the gastric air bubble is gone, and therefore one might suspect there was a very bad peptic ulcer in the lesser curvature of the stomach that eroded through the entire stomach wall, and the air escaped through that hole and got lodged on the other side underneath the right dome of the diaphragm. Another cause of abdominal pain associated with vomiting that requires urgent referral to the hospital is intestinal obstruction. Intestinal obstruction is defined as mechanical obstruction or blockage of the bowel. It could be previous surgery, which anytime you go into the abdomen and you take out organs, you take out the gallbladder, you take out the appendix, you take out the uterus. Sometimes there might be bands of fibrous adhesions that are formed post-operatively, and these may cause partial obstruction from the outside. Sometimes you could have a large fungating mass growing in, let's say, the descending colon that partially obstructs the bowel, and you're going to get intestinal obstruction. In children, it could be a piece of small bowel going inside an adjacent piece of small bowel, intussusception, which we will talk about later. That also causes intestinal obstruction. Or if you have a very pendulous, large sigmoid colon, it can twist on itself, and that is called volvulus. All of these will prevent movement of intestinal contents from proximal part of the GI tract to a distal part of the GI tract, and this is intestinal obstruction. Like with generalized peritonitis, it will cause generalized severe abdominal pain, vomiting, and distension, but unlike generalized peritonitis, in which the bowel sounds are absent, the bowel sounds will be hyperactive in patients with intestinal obstruction. And it's the bowel trying to squeeze intestinal contents past the narrowed area in order to get rid of the buildup of fluid. These bowel sounds are often high-pitched, high-frequency, hyperactive bowel sounds, and one name given to them is borborygmi. Borborygmi is an onomatopoeia. The word or term onomatopoeia means it is spelled like it sounds. So what sound does a snake make? Hiss. It is spelled Hiss. What sound does a duck make? Quack. Quac. What sound does a horse make? Neigh. 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 What sound does a hyperactive bowel sound like? Borborygmi. And you can identify with that if you are extremely hungry and you're having hyperactive bowel sounds, pushing empty air around. It will go, feed me quickly. Management of a patient with suspected intestinal obstruction is refer urgently to the hospital. In the hospital, in the ER, they will order again an erect abdominal film, and what you're looking for is multiple air fluid levels. This is what the multiple air fluid levels in an erect film looks like. And what the radiologist is going to do, and you can do this, is the radiologist is going to measure the distance of the dilated loops of bowel. And if this is less than 5 centimeters in diameter, it is small bowel obstruction. If it is greater than 5 centimeters in diameter, it is large bowel obstruction. So we have several dilated loops of bowel. Here, there, there. And what we see in this particular one is the classic air fluid level. Air up at the top, fluid down at the bottom, and the edges of this horizontal, because remember this is an erect film, are going to go up slightly at the corners. That's the sign of the meniscus. So we have several air fluid levels here. We have several loops of distended bowel, none of them greater than 5 centimeters in diameter. And if you were to watch this carefully, you're going to see thin lines going around in a circle in some of these folds. And this tells me that this is small bowel because those folds represent something called, they're folds of mucosa on the inside of the bowel known as plica circularis. Here's another erect film of the abdomen in a patient with intestinal obstruction. If we measure the widest diameter of these individual distended loops, you will find that they are approximately 3 centimeters, which brings them under the 5 centimeter rule, that if it is less than 5 centimeter, it's small bowel obstruction, greater than 5, large bowel obstruction. Again, we can see the circular folds that are present within each of these distended loops. These are the plica circularis that are found on the inside of the small bowel. The particular sign that is here is called the step ladder sign, and here is one step, second step, third step, fourth step, fifth step in the step ladder sign. Here's another one, similar presentation: abdominal distension, vomiting, pain, hyperactive bowel sounds, and you measure the diameter, and it is 7 centimeters here. So obviously this is greater than 5 centimeters, and this would be large bowel obstruction. And you can confirm this is large bowel obstruction in that you're seeing incomplete folds of mucosa, and this represents the haustration that are classic for large bowel anatomy. Here's an interesting one. This is a similar picture, older man with onset of abdominal pain, abdominal distension, vomiting, no passage of stool, constipation, no passage of gas, flatus. And when you did an erect film of this patient, you see this large distended loop of bowel shaped like an inverted U, or the name given to this in radiology is the coffee bean sign. The coffee bean sign is of a particular cause of intestinal obstruction, and the cause is volvulus. A piece of bowel, in particular, this is the sigmoid colon, has twisted upon itself around its vascular axis and becomes distended. Trapped air can't come out. There's no food going in. There's no food or air going out. And this is what was found on opening the abdomen. And all you need to do is Twist this in the opposite direction. Usually it's a 1.5 twist clockwise, and then you have to do it 1.5 times anti-clockwise, and you know that you have succeeded because that 3 to 5 liters of gas that is stuck in this will then immediately be expelled from the patient's anal orifice, and the operating room will be filled with noxious fumes for the next couple of minutes. Another cause of abdominal pain with vomiting is diabetic ketoacidosis. This is defined as excess ketone productions that is usually seen in type 1 diabetes mellitus. Often the trigger is an infection. It could be a bladder infection, it could be a pneumonia, it could be infection anywhere else, and it throws the insulin balance out of whack. Patient clinically will present with acetone breath, Kussmaul's breathing, which is deep, rapid respiration, otherwise known as air hunger, abdominal pain, and vomiting. Management is refer urgently to the hospital. In the hospital, they would confirm the diagnosis that this is diabetes by having a very high blood sugar, and confirm that this is ketoacidosis by finding excess ketones in the urine. That is termed ketonuria. A comprehensive metabolic panel will show a marked elevation of your serum potassium. And in fact, it's the serum potassium that is the chemical mediator of pain, the abdominal pain perceived in a patient with diabetic ketoacidosis. This patient would be treated with large doses of insulin to bring the blood sugar down, correct the electrolyte imbalance, and make sure that the blood sugar is well controlled before they are discharged. If there was a concomitant infection, they would deal with that at the same time too. Any questions? The next triad of diseases causing abdominal pain is confined to women, and this is women with a problem with their menstruation. The first is pelvic inflammatory disease. PID is defined as the inflammation of the internal organs in the female. So the vulva and the vagina are not part of the internal organs. It's the cervix, the uterus, the fallopian tubes, and or the ovaries in the broad ligament. Common causes of PID, pelvic inflammatory disease in America, would be first chlamydia, followed by gonorrhea. Clinical picture: patient, female, will present with severe lower abdominal pain, usually suprapubic in nature to start off with, and they spread to the right or left side or to both sides. There's going to be dyspareunia, which means painful sex. There's going to be dysmenorrhea and a purulent vaginal discharge, but it's not the vagina that is inflamed. The discharge appears in the vagina, but is actually coming from the inflamed cervix. And here is a picture during a gynecological examination using a speculum, visualizing the inflamed cervix from which the purulent, thick, whitish yellow discharge is coming from. If you make the diagnosis of pelvic inflammatory disease in a female with abdominal pain, dysmenorrhea, and dyspareunia, refer the patient to the hospital. In the hospital, the ER docs would order an ultrasound, transvaginal ultrasound, and what they're looking for is pus in the pouch of Douglas, otherwise known as the rectouterine pouch. complete blood count, because this is a bacterial infection, would obviously show raised white blood cells and neutrophils in excess. The next cause of abdominal pain in a female with a menstrual problem is a complication of pelvic inflammatory disease that was not treated properly. Ectopic pregnancy is defined as pregnancy outside of the uterus. This accounts for 1% of all pregnancies worldwide, and the most common site, 98% of all ectopic pregnancies, occur in the fallopian tube. Most common cause would be previous pelvic inflammatory disease. Clinical picture is you have a sexually active female with 6 to 8 weeks of amenorrhea, so that's the menstrual problem, no periods for the last 6 to 8 weeks, presenting with lower abdominal pain. That is all you need. Female, amenorrhea between 6 to 8 weeks, lower abdominal pain. You have to make the diagnosis of ectopic pregnancy. Should you make the diagnosis of ectopic pregnancy in the primary care setting, refer urgently to the hospital. If the patient has ectopic pregnancy has ruptured and there is blood pooling in the pelvic cavity, then the patient would start to present with signs and symptoms of shock, drop in the blood pressure, increase heart rate, and or pain in the shoulder. This is called Kerr sign. Should that happen, call 911, because this patient could easily bleed out rapidly if this is not caught urgently and treated surgically. In the hospital, they will order an ultrasound of the pelvis, abdomen, and they're looking for the gestational sac outside of the uterus. They would also obviously confirm the patient is pregnant by doing the beta-HCG serological test. This is what the ultrasound of the lower abdomen would look like in a female with abdominal pain, and this particular one had 6 weeks of amenorrhea. Here is the uterus. Here's the uterine cavity. Here is the fallopian tube and the gestational sac growing inside the fallopian tube. And this is an unruptured ectopic pregnancy. The next cause of abdominal pain in a female with a menstrual problem, and the menstrual problem here is dysmenorrhea, is endometriosis. Endometriosis is a condition in which endometrial tissue is found outside of the uterine cavity. It may be found on the ovary, not in the ovary. It may be found on the broad ligament, or it may be found on the omentum or pieces of bowel in the pelvic region. The cause of this is hypothesized to be retrograde menstruation, when a woman at the end of her menstrual cycle bleeds. Among the tissue is living endometrial cells and dead endometrial cells, and they postulate that in some women, the menstrual tissue, instead of going all the way out through the cervix into the vagina and then out, can go back up into the fallopian tubes and then drop out through the fimbriated end of the fallopian tubes onto the outer surface of the ovary, broad ligament, or omentum, or bowel. Usually small bowel lies in the pelvis in the midline. This does not explain why you might have endometrial tissue occurring outside of the abdominal cavity, in the neck or other places in the body. That Picture for endometriosis is classic severe dysmenorrhea, usually within 6 months or a year of the young teen um, starting seeing her first period. This is going to then lead eventually to severe dysmenorrhea and infertility. In fact, it is estimated that the most common cause of infertility in females in the fertility clinics in the United States is endometriosis. Co-manage with a gynecologist who will order an ultrasound, and then the gold standard for diagnosing endometriosis is a laparoscopic biopsy. During the laparoscopic examination, they will see these dark brown chocolate cysts, which are actually uh, cysts that are lined by endometrial cells, and the cysts are full of decomposed blood. So, chocolate cysts biopsied uh, after a laparoscopic examination is the gold standard for the diagnosis of endometriosis. Unfortunately, worldwide, it takes approximately between 6 to 8 years for a woman with endometriosis to be diagnosed as having endometriosis. And we really don't understand why this is so. They thought that at some stage the majority of gynecologists were men who don't quite understand the female um, anatomy and psyche and tend to dismiss if you're complaining of excessive pains during periods. It's just dysmenorrhea. Take Brufen or Aleve, or we can put you on the contraceptive pill, and you should be right as rain. And they continue with this chronic pain that is worse towards the end of their cycle until somebody actually says, let's do an ultrasound of your pelvis, or let's look inside your abdomen and see if there's anything specifically going on that we can treat a little better than just putting you on pain relieving meds. Any questions? The next triad we are going to look at is the triad of abdominal pain and jaundice. Remember, there are two other words that the boards can use for jaundice. One of them begins with I and the other begins with H. So, does anybody remember the Greek word that begins with I that says this patient is suffering from jaundice? And if you said icterus, you would be correct. Icterus. Icterus is the Greek word for yellowness of the sclera and skin. Jaundice is the Latin word for the same yellow discoloration. The third word is hyperbilirubinemia. Hyper means excess. Bilirubin obviously relates to bilirubin. Emia, the suffix emia, says there is excess bilirubin in the blood. Note in my definition of jaundice, I didn't say anything about the color of the urine, because sometimes the urine, depending on which type of jaundice this is, might be normal in color, or it might be darkish green or brown because of excess bilirubin in the urine. Again, we're going to just briefly review bilirubin metabolism. Bilirubin metabolism is broken down into three phases. The first phase, as the red blood cell gets older, or if it's a deformed red blood cell, it gets into the spleen. It is broken down. The hemoglobin is released. Heme is released from the hemoglobin. Biliverdin is formed from the heme. And then biliverdin is converted into bilirubin. That bilirubin has two names: indirect bilirubin or unconjugated bilirubin. From a physiological perspective, I would prefer you to remember, we did this in week 3. So this is just a reminder of what we have done before. That bilirubin, from a physiological perspective, is called unconjugated because it has not yet passed through the liver where it's going to be attached to glucuronide and then forming conjugated bilirubin. The other term that is used is indirect versus direct. Only the lab uses the term indirect and direct. Now, what you need to remember that this bilirubin that is called indirect or unconjugated bilirubin is insoluble in water. Remember that. Unconjugated or indirect bilirubin is insoluble in water. So that if you have an excess of this indirect, insoluble in water bilirubin, the urine in a patient with jaundice, this kind of jaundice that is called prehepatic jaundice, the urine would be absolutely normal. Now, what happens to this indirect unconjugated bilirubin? It is carried via the portal vein, carried by the carrier protein albumin, delivered to the hepatocytes in the liver, where it's going to then be married, conjugated with glucuronide, and this now changes the name of the bilirubin and it changes the role or solubility of the bilirubin. So indirect bilirubin becomes direct bilirubin. Unconjugated bilirubin becomes conjugated bilirubin. And remember that indirect unconjugated bilirubin was insoluble in water. You now change the solubility effect. It is now soluble in water. Direct bilirubin. Direct bilirubin is then excreted from the liver, goes via the common hepatic duct into the cystic duct to be stored, concentrated in the common bile duct and in the presence of CCK, which is released from the eye cells due to the presence of fat in the duodenum. CCK, cholecystokinin, causes contraction of the smooth muscle in the gallbladder, relaxation of smooth muscle in the sphincter of Oddi, and conjugated direct bilirubin then enters the bowel via the common bile duct. When it gets into the bowel, it is going to be broken down by bacteria into a compound known as urobilinogen. Some of that urobilinogen is absorbed back into the blood. Some of it goes back to the liver. This is known as the enterohepatic gut to liver circulation, where the urobilinogen is going to go back into the liver to help in the manufacturing of bile salts. Some of that urobilinogen that was absorbed back into the blood goes to the kidney, excreted in the kidney, and when it is oxidized in the urine, it gives the urine the typical faint yellow color. So urobilinogen is oxidized to urobilin, which gives the urine its faint yellow color. The remainder of the urobilinogen in the bowel continues to be broken down by bacteria. Eventually, it's going to be converted to stercobilinogen. When stercobilinogen is oxidized, it becomes brown in color, and therefore it is going to color the stool brown. When you have jaundice, and again, jaundice is the yellow discoloration. Other word for this is icterus. Other word for this is hyperbilirubinemia, due to this excess bilirubin accumulating in the skin and the sclera. So that is the definition of jaundice. As I said to you, based on the normal physiology of bilirubin, bilirubin undergoes a prehepatic phase in the spleen. it undergoes an intrahepatic phase in the liver and then undergoes a posthepatic phase after it leaves the liver. There are 6 diseases that we're going to talk about. Only 3 this time, and we'll talk about the 3 others later on. We're going to break the pathological causes of jaundice into 3 phases: prehepatic, intrahepatic, post. And for each of these, we're going to have 2 causes. Prehepatic, this is what happens before it gets to the liver, usually in the spleen. It could be hemolytic anemia or sickle cell disease. Now, sickle cell disease is in red. There's a plus next to this, and that plus means of the 2 conditions, sickle cell disease is painful. And we're going to repeat the same pattern. One of the 2 causes of intrahepatic jaundice would be painful. One of the 2 causes of posthepatic jaundice would be painful. Intrahepatic means something going wrong with the liver. The 2 causes are hepatitis and cirrhosis. Hepatitis is painful, cirrhosis is not. And posthepatic jaundice, 2 causes: stone in the common bile duct, blocking the flow of direct conjugated bilirubin from the liver going into the bowel is going to be painful. Carcinoma of the head of the pancreas, which is another cause of blockage of the common bile duct from the outside, usually is painless in the early stages of this particular cancer. So you can see from these 6, there are 3 causes of jaundice that are painful. 1 prehepatic, 1 intrahepatic, and the third one posthepatic. And we're going to use that information, whether there is pain or not, to help us to determine which of the 6 causes of jaundice is the most likely diagnosis. We're also going to use 2 other things. We're going to talk about the color of the urine. Remember, indirect bilirubin, otherwise known as unconjugated bilirubin, is insoluble in water. And if you have sickle cell disease or another variety of hemolytic anemia, the patient would have yellow skin, yellow sclera, but normal colored urine. Remember that after the unconjugated indirect bilirubin gets into the liver to be conjugated, then it is passed out into the bowel. And if you have an obstruction at the level of the common bile duct, either by a stone inside the common bile duct or outside constriction by the carcinoma of the head of the pancreas, no bilirubin is going to get into the bowel, and therefore there's going to be no urobilinogen found, none in the urine. And because there's going to be no urobilinogen left in the bowel, there's nothing to then form stercobilin to color the stool brown, and therefore the stool would not have a brown look. It would have a clay colored look. So we're going to look at the color of the urine. We're going to look at the color of the stool to help us to remember or to work out which of the 6 causes of jaundice would this more likely be due to. So here are the 3 questions. If you have a patient with jaundice, and you can confirm the jaundice by seeing the skin being yellow and the sclera of the eye being yellow, you ask the patient what's the color of the stool. If the stool is normal color, meaning brown, you go to the next question, which is the color of the urine, and then you ask the 3rd question. However, if when you ask the patient what's the color of the stool, you get it's grayish, it's pale, it's not brown. This is described in the medical textbooks as clay colored. Then the next question you're going to ask the patient, because if this is clay colored stool, you know that you're dealing with post-hepatic jaundice. And the only next question you need to ask is there any pain? Because if there is pain, it will tell you that the most likely cause of post-hepatic, otherwise known as obstructive jaundice, is a stone in the common bile duct. And if the jaundice is painless with a clay-colored stool, it would mean a carcinoma of the head of the pancreas. As I said, if the answer to the first question, what's the color of your stool, it's normal brown color, you go to the next question, which is what's the color of your urine? If the urine color is normal, then you know it is prehepatic jaundice. And then the third question you're going to ask is there any pain? If there is pain, it's more likely to be sickle cell disease, which occurs in young African American children or black people around the world, especially those living in the tropics. And if there is no pain or the patient is white, you can think of could this be hereditary spherocytosis or one of the other odd common causes of hemolytic anemia like pyruvate kinase deficiency or glucose 6-phosphate dehydrogenase deficiency, otherwise known as favism, because every time patients with G6PD deficiency have a meal of broad beans, there are two compounds in the broad beans that triggers excess hemolysis, and this will then present with painless jaundice in a white person. If when you ask the question, what's the color of the urine, they say my urine is green in color, or sometimes they say it's dark brown, then you know. If the color of the stool is normal and the color of the urine is dark green or brown, then you know that it's not prehepatic, it is not posthepatic, and the only other hepatic group to deal with is intrahepatic. And then you ask the third question in that situation. Is there any pain? If there's pain in the right hypochondrium, the cause of intrahepatic jaundice would be hepatitis. If there's no pain, it is cirrhosis. It is that simple. So out of the 6 causes of jaundice, only 3 of them present with abdominal pain, and we're going to deal with those 3 right now. So the first is sickle cell disease. This causes prehepatic jaundice. Sickle cell disease is an autosomal recessive condition which affects a small percentage of African Americans, and the patient will present typically with jaundice, with abdominal pain, usually on the left upper quadrant, and it's due to splenic infarction. And remember, your spleen lies underneath the rib cage on the left side in the left hypochondrium. In addition, the patient might have splenomegaly and hepatomegaly. Should you suspect a patient with abdominal pain, young black child, of having sickle cell disease, because their sclera is jaundice and their urine is normal in color, refer them urgently to the hospital. The hospital would then confirm the presence of red blood cell sickling in low oxygen situations. And then the gold standard is to do hemoglobin electrophoresis, which will then identify the abnormal hemoglobin S that is characteristic of sickle cell disease. They will then treat the pain and correct the triggers. There are 3 triggers that would trigger abdominal pain or a bone crisis in a patient with sickle cell disease. Fever of whatever cause it is, whether it be an infection, hypoxia, and acidosis. The next cause of painful Uh, Jaundice, painful, meaning abdominal pain, and jaundice is hepatitis. Hepatitis is inflammation of the liver. It could be viral, it could be chemical, it could be drugs, or it could be alcohol related. Viral causes of hepatitis include hepatitis A, B, C, and E. Remember, D does not cause liver inflammation on its own, but if it is combined with hepatitis B, it's going to cause a really nasty bad case of hepatitis. Chemicals like carbon tetrachloride, dry cleaning agent, drugs like acetaminophen, otherwise known as Tylenol, can destroy, damage the liver to cause jaundice, or if you've had too much alcohol, acutely you can suffer from alcohol poisoning, and this could also present with painful jaundice. Patients with hepatitis will present with right upper quadrant pain, tender hepatomegaly, and obviously jaundice. The eyes and the sclera and skin would be yellow tinge, and in the case of hepatitis, the urine would also have excess amounts of bilirubin inside. Labs, you're going to order a comprehensive metabolic panel. You're looking specifically at the liver function test portion, and you're going to see raised bilirubin. Remember, the boards might not give you these two words for raised bilirubin. They may give you one word, hyperbilirubinemia, which means the same thing. Your AST and your ALT and your alkaline phosphatase, which are enzymes that are related to your damaged hepatocytes, will spill out into the blood. And also remember, if this were alcohol induced, then your GGT will be markedly elevated. If the hepatitis was caused by any one of these four viruses, then serological tests are going to be done to identify the antibodies against hepatitis A, B, C, or E. Remember, the two that are going to be blood borne as opposed to the two that are going to be orofecal. Orofecal would be A and E, bloodborne would be B and C. If you have a patient with jaundice presenting in your clinic, the advice is to refer them to the hospital. Let the hospital determine what is the cause and treat it if it is possible, and then manage this patient. The third cause of abdominal pain with jaundice is a stone in the common bile duct. The term for stone in the common bile duct is cholelithiasis. Lithiasis means stone, chole means bile, doco means duct. So if you see the term cholelithiasis, don't freak out. Just recognize chole as bile, lithiasis as stone, put the two together, and this is a stone in the common bile duct. So this is defined as an intrinsic blockage of the common bile duct caused by migrating gallstones from the gallbladder through the cystic duct and getting stuck somewhere along the common bile duct before it gets to the ampulla of Vater. Classic picture with stone in the common bile duct is severe epigastric pain, jaundice with clay-colored stool, and no bilirubin in the urine. Remember what I said to you back in week 4, that this is the only test that I could think of where the absence of a finding is significant. Not the presence of excess, but the absence of this particular compound in the urine is clinically significant. Refer these patients to the hospital. They will confirm the presence of the stone in the common bile duct, either with an ultrasound or a better imaging would be a CT scan, and arrange for a general surgeon to go in there and extract out the stone from the common bile duct. And if there are other stones in the gallbladder, take out the gallbladder at the same time so that you don't have to have a recurrence of another stone migrating into the common bile duct, causing this problem to recur. Here is the CT scan of a patient with a stone in the common bile duct. This is the pancreas. This is the head of the pancreas. That there is the common bile duct, and here is the stone. So they're going to go in there and take that stone out, and here is the gallbladder. And the gallbladder has many more stones inside there. So they're going to do a cholecystectomy at the same time to prevent a recurrence of this condition. Any questions? Let's look at another diagnostic triad, which is going to be abdominal pain associated with bright red blood in the stool. Bright red blood in the stool is also known as hemato, to do with bloodchesia, to do with the stool. One of the causes of bright red blood in the stool and abdominal pain is intussusception. Intussusception is defined as the telescoping of one part of the bowel into an adjacent part. Most of the times the cause is unknown. Occasionally it might be associated with an intestinal polyp or hypertrophy of the lymphoid patches known as Peyer's patches in the small bowel, the ileum in particular. You have a viral infection. The virus goes and is trapped in Peyer's patches. Peyer's patches become swollen. It appears to the ileum that there is a large piece of fecal material, food, possibly undigested, is going to get hold of this, and with their segmental contractions is going to push this along, and what that is going to do is pull the inside of the small bowel into a nearby loop of small bowel. So here is the proximal part going into the next part there. So here is it. Here is the proximal part going into the distal part. This occurs primarily in children who would then present with abdominal pain, usually periumbilical because it's a small bowel. Most of the times this is an ileal intussusception. Will present with periumbilical pain. There's going to be vomiting, and the blood is going to have, in the stool, is going to have a particular appearance. That appearance is known as red currant jelly stool. Not red currant jelly sputum, red currant jelly stool is passed out. And that combination is classic for intussusception. Should you suspect intussusception as the cause of abdominal pain and vomiting in a child, refer the patient to the hospital. They are going to do a barium enema to try and relieve this if this happens to be lower down in the large bowel, because there are other places besides the ileal intussusception. It could be ileocolic or it could be colocolic in location. If it is not in the large bowel, then a barium enema is not going to be useful, because they're going to use the pressure of the barium enema to push the bowel that is invaginated back out. Then you have to go in there through an abdominal incision and pull the two ends apart. Wait a little while to see whether the blood supply is going to be restored. If not, then you take out the dead piece of bowel and do a ileal anastomosis. Labs, ultrasound, or spiral CT scan is going to confirm the diagnosis before the patient is taken to the surgical suite. And what you're looking for in both the ultrasound and or the spiral CT scan is something called the donut sign. And here is the donut sign seen on ultrasound of the abdomen. Here is the outer part of the bowel. Here is the inner part of the bowel. And this darker areas where you have edema surrounding the squashed inner part of the bowel. This is your classic donut sign. Similar picture is going to be seen in a CT scan of the abdomen. Here is the CT scan of the abdomen. Remember, this is the right side, this is the left side. So here is the donut sign. The outer rim is the bowel into which the adjacent bowel has invaginated. And that's your classic donut sign. The second cause of abdominal pain with hematochezia is an uncommon condition known as Meckel's diverticulum. This is a congenital small bowel problem where you have an outpouching in the ileum. This occurs in 2% of the general population. It's approximately 2 inches long and it is found 2 feet proximal to the ileocecal valve. It is twice as common in male children as opposed to females, and normally the diverticulum, since it's a small bowel diverticulum, will be lined by columnar epithelium with a brush border. Occasionally, there might be two possibilities of ectopic tissues found in Meckel's diverticulum. It could be either gastric epithelium or pancreatic tissue. Remember, Meckel's diverticulum is also known as the diverticulum of twos because I'm going to repeat this again. It occurs in 2% of the population, is 2 inches long, approximately 2 feet from the ileocecal valve, so it's in the ileum. Twice as common in male children as opposed to female. Two possible ectopic tissues, gastric or pancreatic, and therefore you could have two possible complications, either perforation of the diverticulum due to either acid eroding through the wall, or the pancreatic digestive juices eroding through blood vessels, and this will then cause blood in the stool, bright red blood in the stool. The actual cause of this is unknown. We know it's not genetically inherited, but we have not pinpointed if there's any antecedent infection like congenital rubella or some virus that makes these babies develop Meckel's diverticulum more than others. The classic picture is a young child with recurrent periumbilical pain radiating to the right iliac fossa. So it might, in the initial presentation, look like appendicitis, periumbilical pain radiating to the right iliac fossa. However, in this situation, Meckel's diverticulum, there will be no fever. If there is fever, this is more likely to be acute appendicitis. No fever, gonna watch this. If the patient starts to pass bright red blood in the stool, you go, oh, I know what this is. This is Meckel's diverticulum. We're going to refer this patient to the hospital. They're going to do a particular scan. It's called technetium 99. In this particular scan, they're going to inject a small amount of a radioactive dye into a vein in the arm, and then take a picture later of the abdomen and see where this technetium 99 is going to be concentrated. Normally, technetium 99 is picked up by gastric mucosa, that's the stomach. When it passes through the bloodstream, it goes through the kidney, filtered out, and is excreted in the urine. Here is the faint outline of the left kidney, and this is the ureter on the left side. This is the ureter on the right side. However, we have a relatively large deposit of technetium 99 outside of the stomach, the kidney, ureter, and bladder. And this is in the region of where the ileum is located in the right iliac fossa. So with this picture being positive, then it tells the surgeon, the pediatric surgeon, yep, you can put money down. You're probably going to find Meckel's diverticulum arranged to have it removed, because it could be, as I said, complicated either by bleeding or perforation related to either gastric ectopic tissue or pancreatic ectopic tissue. And then the last of the causes of abdominal pain and hematochezia is a rare condition known as Peutz-Jeghers syndrome. This is an inherited condition. The other name for Peutz-Jeghers syndrome is familial. It runs in family. It's adenomatous polyps in the colon. The cause is an abnormal gene mutation. The gene mutation is called the APC gene, and the APC in APC gene means adenomatous, so it is glandular tissue, polyposis, number of polyps in the colon. So adenomatous polyposis coli is the gene, and this runs in families. The clinical presentation is that the patient is going to complain of abdominal pain. There's going to be bright red blood in the stool, and when you examine the oral cavity, you're going to find this darkish brown black pigmentation of the mucosa on the inside of the lips and the cheek and the gums. And the combination of the oral pigmentation, abdominal pain, and hematochezia makes the diagnosis of Peutz-Jeghers syndrome. Um, Diagnosis is going to be clinched by doing a colonoscopy, which will show thousands of these adenomatous benign polypoid lesions. So the management, because this patient presents with abdominal pain and hematochezia, is refer to the hospital. Any questions? All right, let's look at three other causes of abdominal pain that don't quite fit into the previous triads that we've just discussed. First is tertiary syphilis. Tertiary syphilis, by definition, is stage 3 syphilis. Syphilis is caused by a sexually transmitted spirochete called Treponema pallidum in the adult population, and then it's one of the tortuous complex, which will be transmitted from the infected mother during pregnancy via the placenta to the unborn child. It's the S in the tortuous complex. Patients with abdominal pain that are related or is caused by tertiary syphilis will complain of lightning abdominal pain, severe sharp abdominal pain that lasts less than a couple of seconds, only to disappear and come back haphazardly. There's no rhyme or reason. It doesn't come on when they're stressed, when they're hungry, when they're filled. It just zaps them out of the blue. How do you know that this is tertiary syphilis? You are going to look into their eyes. You're going to test their pupils. You're going to shine the light in both eyes. And if you find one pupil does not constrict when you shine the light in it, but it constricts when you do the accommodation reflex, then that is the essence of the Argyll-Robertson pupil. It could be unilateral, it could be bilateral. It is evidence that the syphilitic spirochete has damaged the brain, in particular the midbrain, and in particular the Edinger-Westphal nucleus, to then result in this problem. Labs that are going to be ordered are one, the screening test, VDRL, which is usually going to be positive, and this would reflexly lead to in the lab. Once the VDRL is positive, then the lab is going to do automatically, without you asking for it specifically, the fluorescent treponemal antibody absorption test. Management is refer the patient to a neurologist who will then further treat this patient with long-acting penicillin injection and then follow up these patients. Another uncommon cause of abdominal pain, especially in the older population, is mesenteric vascular occlusion. Usually it's a blockage of either the superior mesenteric or the inferior mesenteric. Is more likely to be the superior mesenteric artery, but occasionally it might be the vein that is blocked, superior mesenteric vein or inferior mesenteric vein. The causes would be thromboembolism from nearby aortic atherosclerosis, a plaque, an aortic atheromatous plaque in the nearby abdominal aorta ruptures. Clot is formed. The clot gets dislodged from the abdominal aorta and goes down. The superior mesenteric artery gets blocked somewhere along the line there. Patients with mesenteric vascular occlusion will present with severe abdominal pain with very little physical signs. They will come in groaning. If you ask them on a scale of 0 to 10, how would you rate your pain? They may claim this is 8 or 9 or even 10. You examine the abdomen and it's soft and tender. There's no organomegaly, no deep or superficial tenderness. You're going to be wondering, are you kidding me? Are you here for drugs? And then send the patient out dismissively. These patients are likely to go home, suffer further complication of the deprivation of blood supply to the bowel, and then come back 12 hours later with complications. Should you suspect this, refer this patient to the hospital. So you're looking for this in older males who are smoking, who are overweight, and who have hypertension. Some of the high risk factors for atherosclerosis. If this were a younger female, it most likely might be due to venous thrombosis in the superior mesenteric vein or inferior mesenteric vein associated with oral contraception, and they may have a history of a family history of DVTs. When you refer the patient to the hospital, put boldly in your referral letter, please consider the possibility of mesenteric vascular occlusion, just in case the patient arrives in a busy ER, there's been 3 accidents, there's been 3 gunshot wounds, and they see this guy groaning and moaning with no real abdominal signs to start off with. Just go home, take 2 aspirin and call me if it comes back. If this were paid attention to, then you can either do a spiral CT scan, which is non-invasive, or you can order an aortic angiogram, which is invasive. So here is the first of a couple of images. This is a CT scan of an abdomen in an overweight male. And what you have here is the superior mesenteric artery, and a large clot from where it comes off from the abdominal aorta to where it starts to give branches to the jejunum. So this is likely to cause an infarction in um, the jejunum and in the ileum, a large part of the small bowel. Here is the same patient with a transverse slice. Here's the abdominal aorta. Here's the inferior vena cava. Here is the superior mesenteric artery. And there's the clot sitting in the superior mesenteric artery. Here is an arteriogram where dye has been injected inside the abdominal aorta, and the dye has outlined most of the superior mesenteric artery right there down at the bottom. There is a blockage. Now note the acute angle at which the superior mesenteric artery comes off of the abdominal aorta. And it's at this site where the acute angulation begins that you're more likely to have turbulence causing atherosclerotic plaque formation. Further down the aorta at about this level, the inferior mesenteric artery comes off at a right angles, and there's less amount of atherosclerotic plaque occurring at that site. Here is what it would look like if the diagnosis was delayed 12 hours. The patient comes back in 12 hours later. He is still in extreme pain. He's now sweating. On examination of the abdomen is now distended. There is tenderness on palpation. And when you listen to the bowel sounds over the area of the bowel that are dead are going to be absent. You're still going to hear bowel sounds because distal to this necrotic piece of bowel, this is about 3 feet of bowel that have to be removed, and then healthy edges reanastomosed. So you want to make the diagnosis before it gets to this stage. If the patient were sent home with some pain relieving medicines, it may take more than 12 hours for the patient to come back to the hospital. It may take this necrotic bowel rupturing in and spilling its toxic bacterial contents into the abdomen, and then the patient is going to develop septic shock. The other disease that is going to cause abdominal pain, which doesn't quite fit into the category we have talked about, is celiac disease. Celiac disease is present when there is a hypersensitivity to gluten, which is found in wheat products. The actual cause of this is unknown. There is a theory that has been pushed for a couple of years that in the days long gone before genetically modified wheat grain and other foods came commercially available, then this was an uncommon problem. With the invention of GMO food, patients are now eating grain that has a high gluten content, and our bodies weren't really designed to deal with gluten as such and develop this hypersensitivity reaction. But the actual cause for the increase in the incidence of celiac disease is not really known. We've blamed put it on. We were not aware of this. Now that we were aware of this, more people are being diagnosed with gluten insensitive or hypersensitivity or celiac disease. Classic picture: abdominal pain with steatorrhea and weight loss. Now, the reason for the steatorrhea, first of all, what is steatorrhea? Steatorrhea is defined as fatty, floating, foul-smelling feces, 4 Fs. Let me repeat that. Fatty, floating, foul-smelling feces. It's foul-smelling because the fat becomes rancid. It is fatty because in celiac disease, the hypersensitivity reaction damages the villi in the small bowel. The villi, instead of being long, uh, like my fingers, they're not actually long like my fingers. So think of the villi as my fingers. When they become chronically inflamed, they shorten like this and become stumpy knuckles. And in doing so, you've actually destroyed the majority of the absorptive capacity of the bowel for lots of nutrients, including fat. And if the fat is not absorbed, so this is not a maldigestion, this is a malabsorption, then the fat remains in the stool, becomes rancid, and then presents as steatorrhea. And any vitamins that are fat soluble, which are depending on the fat being absorbed through the small bowel, in celiac disease, you're going to suffer from varying levels of deficiencies of vitamin D, A, K, and E. As a result of the decreased absorptive capacity of the affected small bowel, you're going to lose other vital nutrients and you're going to lose weight despite a good appetite. They may or may not present with diarrhea that is worse or loose stool that is worse with eating gluten products. So diarrhea is not necessarily one of the classic presenting features. Steatorrhea, yes. Diarrhea, not so much. The diagnosis is clinched by getting a sample of the affected small bowel, looking at it under the microscope, and then you're going to see the characteristic features that are diagnostic of celiac disease. Barring that, the second best test, so small bowel biopsy is the gold standard. Just one step below that is a serological test. You're testing the serum, looking for tissue transglutaminase IgA antibodies. These will be present. This has a very high sensitivity, 97 to 98%. So if present uh, in a patient with steatorrhea, abdominal pain, and weight loss, then the diagnosis of celiac disease is made, and then the gastroenterologist. This is not a diagnosis made by a medical doctor. This is not a diagnosis made or should be made by a chiropractor unless he orders the TTG IgA antibody test. There's another test that we talked about in week 4 when we did in the last hour miscellaneous test. We talked about the D-xylose test. The D-xylose test was a test used many years ago to distinguish between malabsorption, which can occur in celiac disease and Crohn's disease, and maldigestion, which classically accompanies chronic pancreatitis. All three of these conditions, chronic pancreatitis, celiac disease, Crohn's disease, can present with steatorrhea, but only celiac disease and Crohn's disease will have a decrease in the absorption of D-xylose, which is a sugar that when it gets into the bloodstream, there is no metabolic pathway that can handle this. It passes unused out in the urine, and therefore you can pick this up in large amounts in the urine sample that is tested hourly for the next 5 hours. This is a test of historic significance. However, boards has been known to ask these old questions from 30 to 40 years ago. So if you see the test D xylose, it's associated either with celiac disease or Crohn's disease. Despite there being an increase in the TTG IgA antibodies, your IgA antibodies are usually normal in the blood. It's just a subset of IgA antibodies against your tissue transglutaminase that is going to be elevated. Co-manage with a gastroenterologist. Do not put this patient on a gluten-free diet unless the diagnosis is confirmed either by a small bowel biopsy or the TTG IgA antibody test being positive. Any questions? If there are no questions, then we're going to deal with the last of the 26 diseases covered in abdominal pain. It is none of the above. So this is a diagnosis that should be made by exclusion. You need to exclude all of the previous 25 conditions. And when you've done that, then you can make the diagnosis of psychogenic abdominal pain, PAP. It is also known as functional abdominal pain, FAP. And the definition of psychogenic abdominal pain is abdominal pain not related to organic dysfunction. The most common cause is unresolved stress. It may be seen slightly more common in females than in males. The classic picture would be abdominal pain, and if you were to examine this patient's abdomen properly, light palpation, deep palpation, starting off in one quadrant and you going around the clock in the abdomen and light palpation and deep palpation. Remember, you were taught that during palpation of the abdomen, your eyes should not be on where your hands are. Your eyes should be on the patient's face, looking for them to grimace or close their eyes or in some way indicate, yeah, that is painful. The particular sign you're looking for is a sign known as the closed eyes sign. And the closed eye sign we'll talk about later on in the last hour. The closed eye sign is when you palpate an area of the abdomen which is likely to be painful. If the patient closes her eyes before you touch the painful area, that is what a positive closed eye sign is. They close their eyes just before you palpate the painful area. The significance of this sign is it is highly unlikely for there to be significant intra-abdominal pathology. It is more likely that the problem is psychogenic, functional, non-specific, or the term I like to use is supratentorial in origin. Supratentorial, remember the tentorium cerebelli, a tent-shaped fold of dura that separates the big brain, the cerebrum, from the small brain, cerebellum. And if I'm writing in a referral note that I think the problem is supratentorial, most well-educated health professionals would put the term supratentorial and think, I know what the doctor is trying to suggest without upsetting the patient. The doctor is trying to suggest it's in the thinking part of the brain. Because if I were to put psychological as the cause of the pain in the note, the patient, if they read the note before it goes to the doctor, may think, this doctor is wrong. He's telling me this is all in my head. And this is not what I'm implying. It's not all in your head, meaning it could be imaginary. You could have real pain, and if we had a special instrument that would then, if you plug it into the part where the patient is complaining of pain and it registers on this dolorimeter, the pain is 2 or the pain is 6 or the pain is 10. If we had such an instrument, it would register real pain when plugged in over the abdomen. There are no labs that are necessary. This sign, if it is present, is kind of diagnostic. Co-managed with a cognitive behavioral psychologist. The psychologist is going to help the patient work through their emotions and their thought processes and their behavior, and then try and change their behavior as a way to change their emotions, as a way to change their thought processes. Um, I have not encountered any chiropractic case studies written up in the chiropractic literature talking about the uh, efficacy of chiropractic care in a patient with psychogenic abdominal pain. Any questions? If there are no questions, then let's look at reviewing the labs that were mentioned specifically in the last couple of hours. You order a complete blood count if you suspect the patient might have had an anemia. If clinically it was associated with pale mucous membranes, pale smooth painful tongue, or koilonychia, or beefy red tongue. With your anemias, if the patient had abdominal pain with diarrhea, and the pain was on the left side mainly, and there might have been blood in the stool, you suspected ulcerative colitis, and anemia might be present, and therefore you would want to do your complete blood count. And the type of anemia would be a microcytic hypochromic anemia because this is indicative of iron deficiency. Iron is lost with the constant bleeding. If the patient had right-sided lower abdominal pain, right iliac fossa pain with diarrhea but no blood, and you suspected this could be Crohn's disease, then the kind of anemia that would be present would be vitamin B12 deficiency. You would see the beefy red tongue, and when you order your complete blood count, you will then find a macrocytic normochromic anemia that is characteristic of B12 disease, deficiency seen in Crohn's disease. If this were one of the ites that is linked with bacterial infection like cholecystitis, appendicitis, um, bacterial cystitis, diverticulitis, or pelvic inflammatory disease, then the presence of the bacterial infection is going to manifest itself in the complete blood count with a leukocytosis and a neutrophilia. Comprehensive metabolic panel we talked about being useful in the diagnosis of certain causes of abdominal pain. We talked about diabetic ketoacidosis. Diabetes is going to be confirmed by having a uh, fasting blood sugar greater than 126 milligrams per deciliter. We talked also that in diabetic ketoacidosis, there's going to be an increased concentration of potassium in the blood, hyperkalemia, and remember it's the raised potassium in the blood that actually stimulates the nociceptive fibers in the bowel to cause the abdominal pain that is characteristic of diabetic ketoacidosis. We talked about in a patient with Jaundice, you're going to want to order the CMP looking specifically at your bilirubin, your AST, and your ALT. These would be elevated in hepatitis. And if the GGT were also elevated, you can comfortably say that alcohol has played a role in the inflammation of the liver. It has a sensitivity of 75% and a specificity of 85%. Not quite the 90% that we should be looking for, but it gives you a hint that alcohol abuse might be involved. Urinalysis, routine urinalysis is ordered in a patient with abdominal pain, where the abdominal pain is mainly over the suprapubic region. You're looking for evidence that would support bacterial cystitis as the diagnosis. If you find nitrites, then bacterial cystitis is possible. It has a relatively high specificity of 91%. Leukocyte esterase will also be elevated in bacterial cystitis. It has a sensitivity of 85%. And a recent paper has shown if you combine the two, nitrites and leukocyte esterase, you have a much better sensitivity and specificity that you could use both of these if the combination is negative to rule out bacterial infection, or if the combination is elevated to rule in a bacterial infection of the bladder. So the combination of the two has a relatively high sensitivity of 85% and a very high specificity of 98%. The recent study that I am alluding to is a study done on infants who have lost their appetite. They might be vomiting. They go off their food. They're a little squirmy. And remember, infants don't have the capacity to say, when I pee, Papa, it burns me. They just get uncomfortable. They cry a lot. They lose their appetite. They may even vomit or have mild diarrhea. And if you were to catch the urine, or better yet, what they do is they aspirate the urine going through the suprapubic region, so you have a sterile, uncontaminated sample of urine. And when you test both for nitrites and leukocyte esterase, if the test is positive, you can go, okay, the infant has a urinary tract infection. If there is absent, you go, child does not have a urinary tract infection. Maybe we should check the ear out, because children or infants with otitis media can also present in a similar way. They go off their food, they stop suckling, they have mild diarrhea, vomiting, they cry a lot. It could be acute otitis media. We talked about ordering the VDRL test. VDRL stands for Venereal Disease Research Laboratory Test. It's positive in syphilis, but it's also positive in about 60 other situations, including an ordinary rhinoviral infection, certain medication, leprosy, rubella, rheumatoid arthritis. So you need to, if the test is positive, then follow this with your FDA ABS, your fluorescent treponemal antibody absorption test, which is the confirmatory test for syphilis in the lab. We talked about the D-xylose test as a test for malabsorption to distinguish malabsorption from maldigestion, positive in celiac disease, normal in pancreatic insufficiency that is seen in chronic pancreatitis, which will cause maldigestion. And this is an older test that we've used in the past. And as I said before, you need to know this for boards, but just for historical purposes. We talked about the urease breath test. This is a test for H. pylori infection of the stomach, positive in peptic ulcer disease, which is linked to H. pylori infection. And what you're looking for is the expulsion of uh, radiocarbon labeled carbon dioxide being expelled in the breath if H. pylori organism is present in the bowel. Remember, H. pylori is gram negative. It is urease positive, and it's the urease positivity that we are testing for using this particular test. Any questions? If not, let's look at a number of physical signs that we've mentioned directly or tangentially to do with the abdominal examination. One is acetone breath. If you suspect acetone breath in a patient with abdominal pain and you're thinking this is diabetic ketoacidosis, instruct your patient to say Happy Halloween or some other 8 sound like Hanukkah or Happy Anniversary, and you're going to note if the expelled breath has a fruity smell to it. If it does, then acetone may be present in the blood, and this is indicative of diabetic ketoacidosis. You will follow that, making sure that the fasting blood sugar is elevated for hyperglycemia, and you should check the routine urine analysis looking for excess ketones in the urine. And the acetone breath is due to the breakdown of fatty acids needed in order to replace the glucose as the main source of energy in diabetes mellitus type 1. As you break down fatty acids through a process known as beta oxidation, you produce 3 ketones: acetone, acetoacetate, and beta hydroxybutyrate. The acetone doesn't contribute to any further metabolic activity, is expelled in the breath, but your acetoacetate and your beta hydroxybutyrate goes back into the Krebs cycle, from which you're going to generate NADH, FADH2, GTP, which will then go to the electron transport chain and give you the equivalent of 3 ATP from NADH, 2 ATP from FADH2, and GTP is the equivalent of 1 ATP. We talked about listening for vowel sounds with the stethoscope. We're going to use the diaphragm. We're going to remember that the normal range for vowel sounds is between 5 to 34 sounds per minute. This is what Bates' Guide to Physical Examination and History Taking says. You're going to listen 1 minute in each of the 4 quadrants before you say vowel sounds are absent in each quadrant. So listen carefully over a 4-minute period before you go. Breath sounds are not present. Absent breath sounds indicative of generalized peritonitis. Hyperactive vowel sounds are indicative of intestinal obstruction. Bloomberg sign, which is also known as rebound tenderness, is a test for generalized peritonitis. In this particular sign, what you do is explain to the patient what you're about to do might cause some discomfort. So you warn them before, you get permission, and then you proceed to press furthest away from where the patient is complaining of pain. And you slowly push the tips of your dominant hand into the abdominal wall, and then suddenly take your hand off. And when you take your hand off from there, suddenly there is pain. Rebound tenderness is present, Blumberg sign is present. Now, this is a sign that is rarely done today in the clinical setting. Some people claim it's cruel. You know what I'm trying to say? It's cruel. Yes, it's cruel, not cruel de Vil. It's cruel to be doing this because it causes more pain. The equivalent of the Blumberg sign would be the bunny hop. You tell the child, stand on the floor and hop as if you are a bunny, and they take one hop and they hold their abdomen. You go, okay, rebound tenderness is present. It has a, depending on the study, either low sensitivity or low specificity, or high sensitivity, high specificity. But as I said, it should no longer be done in the United States. The next sign we talked about was the closed eyes sign. Patient closes their eyes just before the tender area in the abdomen is palpated. This is the paper written up in the British Medical Journal in the 1970s. The paper was entitled Closed Eye Silent Aid to Diagnosing Non-Specific Abdominal Pain. Today, we don't use the word non-specific abdominal pain. We can use the word functional abdominal pain, or we can use the word psychogenic abdominal pain. So it's 1988. Relatively high specificity, not so high sensitivity. A positive sign, meaning the patient closes their eyes just before the tender area is palpated. Here is the implication. Unlikely for there to be serious intra-abdominal pathology. More likely to be psychogenic in nature. Then there's Cullen sign. Cullen sign is defined as the bluish discoloration around the umbilicus. It is due to the presence of retroperitoneal hemorrhage. It is seen classically in acute appendicitis and in ruptured ectopic pregnancy. It could also be seen in if the patient is on warfarin and they experience some minor trauma to the abdomen. It causes a blood vessel to rupture in the retroperitoneal area, and then it would present as this bluish discoloration around the umbilicus. Gray Turner sign, due to the same retroperitoneal hemorrhage, causes a similar discoloration, except it is in the flanks, at the sides here, not around the umbilicus. So Cullen sign and Gray Turner sign have the same implication, uncommonly seen in acute pancreatitis, especially acute hemorrhagic pancreatitis, and also in ruptured ectopic pregnancy. Here's your Gray Turner sign, where the discoloration is in the flanks. McBurney's sign. McBurney's sign is where there is tenderness on palpation of the right lower quadrant, maximum over McBurney's point. Now, what is McBurney's point? In McBurney's point, you're going to take a line and join the ASIS with the umbilicus, so your straight imaginary line. You're not going to mark the patient's abdomen. You may run your finger touching the ASIS and touching the umbilicus. If you were asked this in part 4, because you have to demonstrate and visualize, you're going to say, I'm going to find the ASIS, draw an imaginary line connecting the ASIS to the umbilicus. I am going to divide this imaginary line into equal thirds, and where the lateral 1/3 meets the medial 2/3, that is McBurney's point. Now, McBurney's sign is if you have pain that is maximum over that point. Now that point, McBurney's point, is actually the surface marking of the base of the appendix, not the apex of the appendix. So let's draw um, the cecum here. This is the cecum. The base of the appendix comes out from the posterior medial aspect of the cecum and then could either hang down here in the pelvis, go in front of the ilium, go behind the ilium, or the most common site of the appendix is retrocecal, behind the cecum. So all of these positions, retrocecal, retroilial, preilial, or pelvic, is variable. The only thing that is not variable is the base of the appendix. And if the tenderness is maximum over the base of the appendix, it is more likely to be appendicitis. The sensitivity is between 50 to 80%. The specificity is between 75 to 86%, not the 90% we are looking for to go, yeah, this is a good sign if it is present or absent, depending on the sensitivity or the specificity, and therefore you should not use the presence or absence of this sign to determine is appendicitis present. You need to have the patient hospitalized. The patient should be examined using a spiral CT scan, which will then document the swollen, inflamed appendix. Murphy sign we talked about when we were discussing acute cholecystitis. In the sign, after you've explained what you are planning to do to the patient and that what you might do might cause some pain and get permission, then you are going to adequately expose the anterior aspect of the abdomen. You're going to place the edge of your right hand just underneath the rib cage where it meets the lateral edge of the rectus abdominis. There's a very specific place. Lateral edge of the rectus abdominis meets the right rib cage. This region right there is the surface marking of the fundus, the most dependent part of the gallbladder. So you put your hand there. Next thing you're going to do is you're going to ask the patient to take a deep breath in. And you're watching their face. Remember, you're not watching your hand or their abdomen. You're watching their face. And if before the peak or the zenith or the top of inspiration is reached, the patient stops breathing and there is a painful expression on their face, this is a positive Murphy's sign. A positive Murphy sign is indicative of acute cholecystitis. The sensitivity is 65%. The specificity is a little higher, 87%, but not quite the 90% we're looking for. The remaining 13% of patients with a positive Murphy sign could be they're having a problem with their liver. So that is Murphy's sign. And then there are other signs that we talked about when we were talking about acute appendicitis. We talked about the obturator sign. Remember, these physical signs are in alphabetical order. The obturator sign, after you've explained what you plan to do with the patient and what you do might be uncomfortable, get permission. I keep repeating this over and over until it is stuck in your head that you have to do this. If given this as a task in your board's part 4, you're going to place the patient in the supine position. You're going to flex the right hip and the right knee. You are going to internally rotate the thigh by bringing the right leg outwards. You're going to pull the right leg towards you, and this will cause the thigh to turn inwards. If this maneuver causes pain in the right iliac fossa, it says appendicitis is present. Not only does it say appendicitis is present, but it's telling you that the inflamed appendix is lying in the pelvis, 35%, or it's 30% of the locations of the appendix is in the pelvis, 65% is retrocecal, and the remaining 5% is in front or behind the terminal ileum. It tells you that the inflamed appendix is lying in the pelvis on the obturator internus, and this is a test where you put the obturator internus muscle on stretch, and it will then pull on the inflamed appendix. It has a relatively high specificity when it is present, but if it is absent, it means absolutely nothing. The next sign that is also done for appendicitis not only will tell you that appendicitis is present, but when the sign is positive, it will tell you that the location of the appendix is most likely in the most common position, which is the retrocecal position. So, in performing the psoas sign test or the psoas test, after, of course, you tell the patient what you're going to do and what you're going to do could cause pain. You're going to put the patient in the left lateral position. You are going to grab the right knee with your right hand. You're going to put the non-dominant hand on the hip to stabilize the hip. You're going to extend the right hip. And if this maneuver causes pain in the right iliac fossa, appendicitis is present. Again, it indicates that the inflamed appendix is in the most common position, retrocecal. Depending on the study, it either has a low sensitivity or a relatively high specificity. The next sign that is associated with appendicitis is your Rolfing sign. Place the patient in the supine position. After you explained what you're about to do and gotten permission, expose the abdomen adequately, you're going to place your examining hand in the left iliac fossa, and you are going to press down ever so slowly in the left lower quadrant. And as you do that, if the patient complains of pain, you ask them, where is the pain being felt? And they should say the pain is felt over on the right side. And if that is happening, your Rolfing sign is positive, and this is indicative of acute appendicitis. It does not tell you where the appendix is. You just moving bowel from underneath your right hand in the left iliac fossa. It pushes the bowel over to the right side, moves, displaces the inflamed appendix wherever it is, and it would be positive if the patient says, yeah, it's painful in the same place where the pain radiated to. Depending on the study, you either have a low or a high sensitivity or specificity. Any questions? If there are no questions, then here is your homework for next week. You're going to read edema in Chiro Essentials Differential Diagnosis. You're going to download the appropriate key words. Okay.